So let me start with the case. This is a 57-year-old woman who had 2 surgeries at Myrtle Beach, and she ended up eventually with L3 to S1 decompressor lami with the deformity you see there on the right. So for some of your deformity surgeons, or all of you guys probably already looking or thinking about the spinal pelvic parameters and what you need to do and all that to correct. She does have a neurologic deficit, left foot drop, but that's not the focus of the talk here. So, what are you going to do? So let's talk about some other things that we need to consider. So global sagittal balance, of course, is very important, but we do need to look at the patient, individual patient, and treat that patient. So you also want to think about non-surgical options. We don't always have to operate on patients with deformity, and is there less invasive surgical options? So if we're talking about other spinal deformity surgery, you do have to take measures to minimize complication. You have to plan ahead. And I was charged to talk about proximal junctional kyphosis and bone quality, so we'll be talking about that a little bit. However, I do want to emphasize preventing complication. That's the talk. It's not always possible, regardless of how much measures you take. You can reduce the chance of complication. So that's one example of this patient of mine who had a very good outcome in terms of deformity surgery. She had a pretty bad sagittal imbalance, but you see that alopecia left by electrode from neuromonitoring. She was not very happy about that because it was in very prominent area. But hair did eventually grow back slightly, so last time I talked to her. So this is another case, 96-year-old gentleman. He was very active until very recently. He was actually driving and bowling with some of his friends. His chief complaint was progressive difficulty with walking. So when he came to me, he was in wheelchair, brought by his children, associated with some chronic back pain. And you have this x-ray that show, and is this something that we would kind of work up with the scoliosis film and think about what we can do to correct his posture and horizontal gauge. So the neurologic exam is a good point to start. He had a spastic gait with 4 out of 5 weakness, not only his legs, but also arms. No pathologic reflexes, interestingly. But we did get an MRI, cervical MRI, and you can see on the right, very large pannus, C2 pannus with severe upper cervical cord compression. So this is 96-year-old gentleman. So do we go ahead and think about operating on this gentleman, or what do we do? Do we just tell him, yeah, we think we know what the problem is, but I think you're too old to operate. Obviously, patient's desire is an important factor, and family also in terms of providing input. But what I want to talk about is rather than age, you have to think about physiologic age. So that's where the frailty comes in. So in his case, I felt that chance of him surviving the surgery, doing well, was very, very reasonable, and his goal was to regain ambulation, which I thought with a more recent, fairly rapid progression that I can achieve. He really didn't care about his back pain. He didn't really care about the deformity that was seen on x-rays. So what I did was I did a decompression and just stabilized him from occiput down to C4. And I was pretty amazed for a 96-year-old gentleman. He bounced back from surgery very quickly with regaining ability to ambulate. This is a much younger patient, a 54-year-old woman, right leg pain, much worse than a low back pain. And she had multiple surgical options presented to her by different surgeons, and one of them obviously was deformity surgery. But when I saw the MRI, I thought she had a right L4 nerve, a foraminal stenosis, and sure enough, with selective nerve root block, her pain went away completely and then came back. So what I did was perform MIS decompression. So you always want to ask the patients what bothers you the most. They have something that presented initially with the healthcare provider for a complaint, and then you ask yourself what is causing that problem. Although spinal deformity surgery does not need to be deformity does not always need to be corrected, and you are already aware, many lumbar spinal stenosis patients, when you do a decompression alone, their sagittal balance improves. So if you do have to, once your decision is made to pursue adult spinal deformity surgery, you want to plan. So preoperative assessment, we're going to talk about frailty very briefly. I think it's more important than age alone, and you want to optimize preoperatively. And then it really helps if you have a dedicated internist, which we do for these patients. And you want to think about the implants you need, a bed that will be ideal. Some of these beds really helpful in terms of actually helping with the deformity correction and obviously neuromonitoring. Think about blood loss you're going to have, what can be used to reduce bleeding. And then I always tell my residents and fellows about the art of surgery. So A stands for aim. What are we trying to accomplish here? So for deformity surgery, you want to think about degree of correction and whether you need to also decompress. And route is, you can go anteriorly as an adjunct or to try to do posterior alone. And where is going to be uppermost and lowest instrumented vertebrae, and what are you going to use in terms of bony fusion? You're not going to have enough autograft, most likely, in these cases. And what are some of the technical challenges? So think about possible complications that can happen. Thoracotomy is very common with these surgeries because a lot of these are revision surgery. Dural kinking with big deformity correction, sometimes that can lead to neurologic deficit. And what are you going to do if there's a signal change where the motor or SSCP drops off? So what are risks associated with other spinal deformity surgery? Operative time, 5 or more levels of fusion, PS or vertebral column resection, revision surgery, and then the list goes on. Age greater than 80, I think that's more related to the frailty, and we will talk about that very briefly rather than true age itself. So frailty is actually a medical syndrome that leads individual to be more vulnerable to developing increased dependency and even death. So when we look just age 80 to 84 as our patient population age, they want to stay active, and some of these patients will come to you seeking a surgical solution. So if you look at over 80, more than 20% will be frail by this definition. And if you think about it, 1 out of 5 patients, if you operate, you're going to actually make them worse. They're going to be either more dependent or they may even die afterwards. So physiologic age is more important than true age in predicting postoperative complications, not only what you would expect, but also wound infection and mortality. So Tilburg frailty indicator is what I like because it is tested, very valid, fairly easy to administer, and it has 3 components included: physical, psychological, and social components of frailty. So if you have a score of 5 or above, then there's a significant perioperative risk, and obviously there's a degree of frailty there. For spine, modified frailty index has been kind of reported along with other scales. I'm not going to dwell too much on that. This only looks into past medical history and functional status. It has found to be superior than age in terms of predicting complications in reoperation, but it's not validated. So how can we avoid returning to the OR? What are causes? Infection, obviously, there are certain things we can take. Measures including vancomycin powder. We use what we call Texas tea, betadine with saline mixture, really vigorously irrigate. And then proximal junctional kyphosis that can lead to failure, pseudoarthrosis, which is delayed, whereas proximal junctional problems are more acute. So this is the definition. I see a red, so that means I think time is, so I'm going to move along very, very quickly here. So it's a type of adjacent segment pathology, and proximal junctional kyphosis, there's different definitions, but I like this one. If there's 10 degree or greater in terms of increase compared to preoperative measurement after the surgery in terms of sagittal Cobb angle, I think that's proximal junctional kyphosis, and very high incidence with that definition, up to 60%. Proximal junctional failure by definition is if there's structural failure that should be addressed surgically. And quite often it manifests with the uppermost instrument vertebrae fracture or level above a fracture, subluxation between those two levels, proximal implant fixation failure, neurological deficit, and as I mentioned, most of the times this happens very acutely, 2/3 in the first 3 months and most within the first 18 months. So what are the risk factors? There's the patient factors, radiographic factors, surgical factors. So let me talk a little bit about radiographic factors. If there's a severe preoperative sagittal imbalance, high thoracic kyphosis, preoperative proximal junctional angle, which is really high pelvic incidence, and surgical factors. One key factor, I think, is injury to posterior complex. Facet violation above where you're fusing, destruction of intraspinal ligaments, and extensive paraspinal musculature. And then you have very, very rigid construct using cobalt chromium rods, and selection of upper instrumented vertebrae is very important, and degree of correction, and anything that destabilizes spine, and fusing down to sacrum, which makes it very rigid. So those are known surgical factors. So going back to the initial case, I was thinking, if I can disarticulate between L3 and 4, you see that there's quite a bit of the coronal deformity there with the lateral listhesis. I thought that I can perhaps avoid the PSO with this patient, and that's what I did. So you can see the image-guided osteotome, and obviously you can see that there are large vessels on the MRI very nearby, so I needed to make sure that I don't go too deep. And then what I did was I went there and kind of disarticulated and then cracked that open so that that would be able to be reduced. So how do I go back? Yeah. So that was before and after, and she did very well with very reasonable correction. And her foot drop is slightly better after the surgery, but we have to kind of see how that goes. So what are some of the strategies to reduce PJK? Proximal protection, so careful soft tissue dissection, trying to avoid getting into the facet. Segment augmentation has been talked about, quote-unquote soft landing, so where you try to go above at this proximal junction with something that's less stiff, less rigid than pedicle screws. Terminal contouring of rods so it doesn't stick out, and using titanium rods instead of cobalt chromium, and expandable screws, and other things have been talked about. And one thing that is very, very related to proximal junctional kyphosis is osteoporosis. So let's briefly talk about that, and then I'll wrap up this talk. It's very common. And osteoporosis, more than 10% of Americans age 50 by using the WHO definition, WHO definition, and then osteopenia is greater than 40%. And then there's many risk factors for osteoporosis. For other spinal deformity surgery, how does it manifest itself? Compression fracture, pedicle fractures, proximal junctional failure, kyphosis, implant failure, and pseudoarthrosis. So what are some of the medications that are out there? I'm going to skip over vitamin D and calcium. Bisphosphonates is an anti-resorptive agent. So what it does is it inhibits osteoclastogenesis. It allows, it actually inhibits resorption of bones. However, when you look at teriparatide, which is synthetic parathyroid hormone, what it does is it actually increase osteoblast activity, thus increase bone mass. So when you look at the literature that's out there, comparing bisphosphonates and teriparatide, teriparatide thus far comes out ahead. There's earlier fusion, higher overall fusion rates, less screw loosening and pull-out. And when you look at postmenopausal women in this meta-analysis, it clearly showed that there's increased lumbar spine bone mineral density with the use of teriparatide. So what is the algorithm? And this I like. So have a very low threshold for checking for osteoporosis. If you look at certain x-rays and CT, you can pretty much tell that patient at the least has osteopenia. But if you have a patient over 65, you should routinely screen them for them with a DEXA scan. You do have to be aware there may be false elevation if patients have degenerative scoli or degenerative changes there, aortic calcification. So you have to look at other parts of the body to see whether the patient truly has osteoporosis or not. And if possible, and most of the deformity surgery is elective, if possible, treat the osteoporosis. And that also conveys to the patient how serious this is. So I have my practice is pretty much everything spine. So a lot of it is very easy, same-day surgery type of thing with decompression. And then this is, so I try to tell them, this is a big deal. You can get worse. And I have kind of really mentioned to them that how big a surgery it is, and part of that is talking about the bone quality and trying to treat that before. So what are some of the surgical techniques if you have to operate on patients with osteoporosis? You can do vertebroplasty or measures to distribute the stress by using hooks, wires, bands, and a double rod technique, or improve pull-out strength of pedicles. So you can use the largest diameter, longest length screw, triangular position of the pedicle screws by cortical purchase, segment and augmentation, expandable screws, hydroxyapatite coated pedicle screws. And then the other strategies avoid putting greater demand on the construct by avoiding over and under correction. We find out more and more that older age populations, they do tolerate greater sagittal vertical access and pelvic tilt, so you don't have to try to make them beautiful. And then there are other adjuncts that you can use, including the use of bone stimulator and custom-made TLS. So for cervical spine, I do a lot of cervical deformity surgery. I'm very quick with using halo vest. So I'll finish with the last illustrative case, a 68-year-old woman who is not only frail looking, but also frail on the frailty index, had osteoporosis with chronic steroid use, comes in with this deformity, chin and chest deformity. And this was one of those patients. I told her, I'm going to have to break your neck to get it back to a more reasonable position, and that's what I did, front and back, and then put her in a halo, and so far she's doing okay. I thought she's going to end up with a distal junctional failure, but so far. So to summarize, the spinal deformity surgery is mostly elective with high risk of complications. So those patients do require special attention. Consider frailty in addition to age. Treat osteoporosis, if possible, before surgery. Proximal junctional failure is early complication that leads to another surgery, so do what you can to avoid that. Pseudoarthrosis is more delayed complication. Preoperative plans to reduce avoidable complications. Intraoperative measures to reduce complications, and postoperative. So it's the whole process. You have to really kind of pay attention and plan to achieve good outcome. If done well, these deformity patients are one of the most satisfied and grateful patients, and this is one of my old patients more than a decade ago with chin and chest deformity, ankylosing spondy, and she sends me a card telling me that she's doing well. Thank you.